So welcome everybody. This is the week of June the 12th. It's Friday. We have a lot to talk about. So let's start the show. For people who don't know me on YouTube, this is a quick background. I have 30 years of experience in the healthcare space, especially launching a product called pulse oximetry, which is in the news with COVID, and a lot of experience in intensive care unit, anesthesia, and I've been running two companies. One is MedStars, which is an advisory company, and HealthTech Capital, which is a group of investors who have invested in 40 companies in the space. So deep knowledge in the area there. And my objective today is to share with you reliable data so you can make your own decision based on facts, and hopefully stay away from some of the emotion and the politics, that's in the press right now. So I was trying to develop a piece of art to make this uplifting. So this is the first one to view my new art, which is the Oriola bird who's eating the COVID and hopefully pushing it to the other space. So that's my representation of what we're doing as humanity here, trying to find the virus. So I hope you like it. So let's go through the update. So Brazil is now number one in the number of daily cases. We'll talk a little bit more about that. South America is now 1 million cases per week. So there, unfortunately, this is the big fear. We've been talking for a couple of weeks that it's moving to the southern hemisphere. The other worry is you see Asia is climbing up here. And that's because India is heating up, especially in Mumbai. And that's a big worry because 40 to 50% of people living in Mumbai, don't really have access to good care and sanity. So that's a big worry that these two things are starting to explode. Iran is having a second wave. The US will spend quite a bit of time on that. It's having an upsurge in more than half of the states. And we'll see what's going on. And then we'll do a bit of a update on what's going on with the disease. There's a new information that's been published in the last week. And then, as you all know, if you look at the stock market, it's going up and down, so we'll talk a little bit about that too. So let's look at the dashboard. We now have passed 7.5 million cases in the world. As you can see from the graph here, it's still going upwards. Now look at some of the new countries there. Brazil is now 800,000 cases, really exploded in the last few weeks. Russia is, especially has a big problem in Moscow. India, Mumbai is also growing extremely fast. It may pass Russia. And then you can see we have a big problem in Peru. It's a small size country, but has a high amount of cases. So let's look a bit what's going on. If you look at the daily reported deaths, so we are averaging, around 6,000, maybe 4,500 deaths per day. But the worrying part is you can see Latin America is the one that's starting to take the biggest chunk of the daily death rate. Good news that North America, was going downwards, but you can really see the upsurge in this area here. So if you do the analysis on the normalized case by million, which is the best way to kind of compare the cases there, you can see Brazil has a huge amount of cases, 154 cases per million. And then Chile is the number one cases. Compare this to the US, which is 62 cases. So the proportions are pretty heavy. So India is really worrisome. It's still a lower amount because there's such a large population there, but it's clearly, a delay upswing, which, so we have to see what happens in the coming weeks. And Mexico and Chile, are starting to emerge. So this is this nice little dashboard where in deep red is the infection rising, and in green, it's basically dropping below the prior peak. So the good news for Europe is that it's clearly on the recovery phase. I mean, Europe is really in good shape. US, you can see we are recovering, but we have some hotspots. So it's a mixed bag. You're going to see some states are doing really great and are getting the disease under control, and other states are really getting accelerated. Africa is growing up in Nigeria and some of those countries there. We don't really have good data reporting, so we have to see exactly what the situation is. And unfortunately, Central America and South America is pretty much dark red. So that's really concerning because the big worry we had several weeks ago is that the virus will move to the southern hemisphere during our summer and their winter, and then come back like the flu season does. So that's really worrisome because it's clearly happening. This is, if you look at the daily case as of today, Brazil now is the #1 with 30,000 cases today. That's astonishing because it's passing the US, which is 22,000 cases, and we have a bigger population there. But look at India. India, for the first time, recorded over 10 to 11,000 cases, and they're clearly on the upswing. So, and then you see Mexico and Saudi Arabia. There's a lot of problem in the Middle East area there on the population basis there. So unfortunately, the number of new cases are going up. The number of new reported deaths was going down, but as you see the emerging of the cases in these emerging countries, the fatality rate, which usually is 2 to 3 weeks after the new case arrive, you can start seeing the upswing over here. So this is an interesting slide. I'm updating this every week. And what it shows is that in Europe, when they had that wave, it really hit the elderly population. But what's in the US, is a younger population on the average there. What's worrisome here, if you look at the fatality rate, Europe had an older fatality rate as a higher fatality rate because of an older population. But you can see that the young emerging countries there, it's a much younger population. And so now we have to keep an eye on that. Part of that, for example, in Mexico, 25% of the deaths are people between the age of 25 to 49. It's not age related, it's really probably social demographics, high density population, a lot of poverty, not access to care, and all of that. So what we are learning is that whatever happened in prior part of the world does not necessarily apply to the new part of the world where the virus is growing. So if you look at on a 2-week basis, which really show growth, you can see Libya and Saudi Arabia, the whole area there in the Middle East is the hottest one, and then Brazil, Chile, Argentina, that whole sector is rising. The good news, we're starting to cool down a little bit in the US in the speed of growth, right? So another way to look at this is the last 7 days, which is more recent. Brazil, as you know, is out of control, unfortunately. And then the Middle East is showing a pretty high rate also there. So, and India is emerging. So that's really worrisome. So all the dashboards, same story there. If you remember 3 weeks ago, Africa was pretty much light colors there. It's really started to emerge with hotspots. And South America, now pretty much the whole continent. Before it was just Brazil, and now it's really spreading everywhere. So this is unfortunately some sad picture there in Brazil. They have such a high mortality rate, they do this mass burial. If you look at the mortality rate, Mexico is at 12%. It's even higher than Brazil. So Mexico is something worrisome because they're probably a couple of weeks behind Brazil in the growth rate. And Chile is totally out of control. I mean, it's really sad what's happening there. So this is a new graphic, and I'll spend a couple of seconds on it. If you look at the mortality rate, Belgium, we talked about in the past as the highest mortality rate. And then this is Wuhan, to give you some perspective. Wuhan's overall, reported close to 8%, half of Belgium. This is the US over here. And so right now we believe it's 4.5%, 5%, we're still kind of going with the epidemic there. So you can see there's a massive difference in fatality rate. Now, part of that may be the reliability of the data, the Chinese data, people in Afghanistan may not be the most reliable, but what you can see, there's a huge differences from places to place. Part of that is the age of the population, the density of the population, the data reporting, and the definition of the data. So let's look at the fatality rate. Belgium is really high, and then you have Italy. Mexico is swinging straight up, has now passed Sweden. Sweden finally recognized that the Sweden experiment did not work, and they end up with only a herd immunity of 7%, which is really too low compared to what the minimum goal is 60% that we discussed before. And so, but there's an interesting thing is that if you travel around the world, you can see that we have really massive upswing in very dense population. Brazil, India, you can see the second wave of Iran is pretty clear cut. There's a tiny bit of a second wave in France, but it's starting from a low level, so hopefully it's not too bad. Mexico, is clearly Pakistan, Saudi Arabia, all of that is very steep incline, so we need to keep an eye on that. Good news is most of Europe, you can see, is really getting very close to back to normal. So that's really good news for Europe. We are the US, we are flat, if not going up. We'll talk more about that. So very different picture, different part of the world. If you look at the mortality per million, which is kind of the way to compare that, we are 351 per million, which is kind of roughly half of Europe. So we've done a good, although we have the virus out of control a little bit in the US, we've done a good job at taking care of people when they got sick. And that may be the healthcare system in the US, is very strong. But if you look at the US, we have 2 million US cases. We passed that. Over 1,000 deaths per day. Let me think about this for a second. Every day, 1,000 Americans die that should not have died. And you can look at the case rate. It looks a little bit on the downside, but you're going to see when we do a deeper dive, there's an upswing going on. So this is something that's worrisome. When you look at the fatality rate, and you look, for example, Belgium, which is showing that 16% mortality rate, and then you look what the seasonal death rate should have been, they report exactly the same bump that they see with holding amount of people dead. If you compare this to the UK, for example, they're underreporting, and so is New York City. And so there was an analysis done, that showed that the true ratio in the US may be 1.5x. So if we have 100,000 people who die, the true amount of people who may have died is 150,000. And that's because there's a difference in how we define. In Belgium, anybody with a suspected death from COVID, despite the fact they may not have had a diagnosis of COVID, is reported as a death due to COVID because of symptoms and other things. In the US and in some states, they only report people who were diagnosed and tested for COVID and then died afterwards. So, and unfortunately, to make things even more complicated, different states do different things. So, for example, in Belgium, 50% of the deaths came from elderly people there, despite the fact only 5% of those people were tested because they had all the symptoms and they rely on the clinician making the decision as opposed to having a PCR test. So be aware when you look at these numbers there, most of the time it's underreported. And that's the argument of Belgium. So the true mortality or related mortality is going to be quite significantly higher than what we're reporting. And, I don't know if it's as bad as what Belgium had, but, there clearly is something there that's reliable. If you remember, I presented a couple of weeks ago, Epic, with the biggest medical record healthcare providers in the US. They do most of the large healthcare system. Did a full analysis in the US showing exactly that mortality rate, and then find out that the mortality ratio was 50% higher than what should have been normally during this time of the year. So we are underreporting in the US. There's multiple data showing that that's an issue there. So now there's this whole issue of probable cases. So somebody died, had a heart attack, a stroke, and they died, and nobody did a biopsy and an autopsy, and they're not being reported because there was no PCR. There's 28 states, so half the states in the country, who are not reporting probable cases. And that ratio is pretty big, okay? So I want you to keep that in mind as we're looking at the states, and we're gonna talk about Arizona and Texas and all of that, and they all have different reporting definitions. So let's look at the new daily cases rising in the US. You can see that 3 weeks ago, we had 1 or 2 states were barely above the R north of 1, which is the ratio of how many patients you contaminate. Now you can see the rise is in now 29 states. It's astonishing. We basically just are having a rebound. Now, how bad it is, we have to take a look. Now, there's a problem in Arizona. They declare a healthcare emergency yesterday because they're running out of space in the ICU. You can see the serious uptick in Oregon, Montana, Utah. You can see the whole case there. It's in a period of 2 weeks, Arizona doubled the number of cases per 100,000. And you can see a lot of these other states, Oregon, South Carolina, these are significant uptick. We're not talking a few percentage increase. You're talking significant multiples. So we need to keep an eye on that. So daily heat map, New York is in great shape. They clearly have controlled it. They have high herd immunity, estimated between 20 to 25% in Manhattan. So there's a slow propagation of the virus. But then you look at Michigan, Arizona, Alabama, very, very big increases in, 2 to 3x's. And then you can see the whole list here. So unfortunately, we don't want to see dark red. That means it doubled versus the prior weeks. And these are significant number because that's how you get this explosive growth of the virus. So if you look at the mortality, there's a paper just came out of the Kaiser Family Foundation showing that across 41 states that provide reliable data, 45% of the deaths are in nursing homes and long-term care facilities. And that's a big problem there because a lot of these nursing homes are facing a restriction or difficulty getting access to PPE, protective gears, as well as having problem having people providing care. And although there are 15% of the COVID cases, you can see the mortality rate is 3 times higher than that. The thing that is interesting, if you compare the mortality rate by age group and you do it below the age of 65, you can see that Belgium, most of the deaths were people in the older age category, especially 80 and plus, so a lot of the nursing home. The thing that's a bit concerning in the US is that we have 30% mortality rate for people below, 30% of the deaths are for people below the age of 65. And so that is something that's roughly 3x Europe. Now, Europe has an older population, so you would expect a higher proportion of their deaths due to the older population there. But there's clearly a bit of a denial, by the people between the age of 20 to 45 that they are at risk and they're taking bigger risk and unfortunately they get exposed, and statistically some of them unfortunately have bad outcome. And then we know that the Black American population has a 2.4x higher risk. The Indian population is 7x, all linked to comorbidity and underlying condition there. And keep in perspective, 41% of the deaths in the US, were due to New York and New Jersey. So let's keep perspective there. I showed this a week ago, but I think it's so hard to get a handle on these numbers. We are already at over 100,000 and we're still on the upswing. We're not a downswing, we may be flat, but we clearly have shown sign of upswing. At a minimum, we're going to double this amount. And if we have another wave and this takes longer because of an upsurge, we're going to get close to some of those numbers here by the time this is finished in the next 18 months. And that's absolutely amazing that in a short period of time, we have a mortality rate that could be as high as some of the World War II deaths. So we need to keep an eye on that. We're already above World War I. So in 3 months, we have more people dead than in a period of 2 years in Europe. This graphic is interesting. I updated it. You can see that Europe has done a really good job to be close to back to normal in the infection rate with a 3-day ailing average. You can see the US is slowly slowing down, but not at the same slope than Europe is. And that's because you have some states going back up and some states going down. And then there's a big difference between Asia and Europe. And we need to understand better why they have done a better job. And I'll talk more about maybe some explanations into why we're having such a high infection rate and mortality rate. So where is the coronavirus on the rise? Keep in mind, if we remove New York, most of the drop in the US is due to New York, having done such a great job. So if you remove New York, we're absolutely flat overall. So the country is reopening. We have to reopen. You cannot lock down the economy, but we are clearly not doing great. If you look at Arizona and all those things, they're all going straight up. So most of the states, including California, is on the upswing. This is another fun dashboard. You can see the little arrows there. Several states are flat, a couple of slightly down, but most of them are up, including Florida. This is the R0. This is a key statistics. This is the ratio between how many people who are infected, how many people do they infect. So the way it gets exponential in the growth of the virus is that we had uncontrolled R0 of 2.5 for this virus. So we want to be below 1. If you stay below 1, the spread of the virus slows down. In the last 3 weeks, if you remember, we had only 2 states who were barely above 1. Now we have 15 states who have gone above 1. Some of them, 1.2. So that trend is going in the wrong direction. That means there's a second wave. We don't know how bad it's going to be, but it's clearly, see the list there, it's clearly spreading. Cases by week, you can see Florida and Michigan and Virginia and Georgia, unfortunately California with a problem in Los Angeles and Texas, all of that are rebounding. And so, and you can see the hotspots, the whole Southeast, Arizona is really hot in red, and then some of the California region there. So this whole area here, which was radiating the virus, and never really closed down or reopened pretty quickly there, he's having an upswing. So another way to look at this, you can see California is clearly going upwards in the last 14 days. That's what you're looking for. So this list, 2 weeks ago, there was 1 or 2 states. Now you can see it's really expanding. The good news, there are some states who are doing great. Pennsylvania, New York, New Jersey, the whole East Coast that took the first hit is getting things under control. Worst outbreak, look at the cities there. These are cities there that from week to week kind of changes. But again, these are not big cities like a Chicago or an Atlanta. These are mid-sized cities there. But it's El Centro, they're having a problem there, which is close to the Mexican border, in the San Diego area there, near some of you. The good, so this is getting darker. It's not terribly bad, except for New Mexico there, but it's going the wrong direction. Let's talk about California. California is still having problem in making tests available to the population there. They're trying to, the goal is 30 cases per 100,000. You can see we're 8 cases per 100,000. We have a long way to go to be able to test the population there. Overall, the positive rate is stable at 4.7%. That means for 100 tests, 4.7 people are tested positive there. Good news is that our healthcare system is in good place. We have capacity to handle it. The bad news, you can see on a day-to-day basis, it's still going upwards. But we never really took control of it. Clearly, the problem is now Imperial and Los Angeles, which is Southern California there. And you can see for some of us, Santa Clara had a bit of an upswing. And so that's a worry here, because now we're going to probably have different rules for different parts of the state. If you look at the Bay Area that most of us are in, you can see Alameda had an upswing. And that has been consistent for the last several weeks. The standard to reopen was less than 2.5 cases per 10,000. You can see that Alameda was 3 times higher than that. So is San Mateo. San Mateo has a hot spot going on. Marine, that was doing great. You can see they reopened and it's straight back up. Santa Cruz and Santa Clara is doing good. In San Francisco, it's not perfect, but it's on the downward slope. So very different picture in different part of the country. So you have to really look at county to county, region by region. And so the big problem we have in California is Los Angeles. Most of the cases are in Los Angeles and San Diego. And the Latino population is being hit at a much higher rate than the mix of the population. And that's because most of them have to go out to work, so they get exposed. They are living in more dense household, over 4 to 5 people in a house. And so they clearly have a high chance of exposure. The good news is that if you remember in the last few weeks, this thing on the ICU availability was on the upswing, so that was concerning. Now we're back to the downswing. So California has a lot of capacity. And this is what we wanted to see. You basically had a decrease in the number of patients in the ICU, in the hospital there. So we're at least, now we have to see if there's an upswing in 2 weeks from now. We have a problem there. So let's talk about the virus. I thought a lot of you are like me, a little bit on the medical nerd side. This is a picture of the virus. It's a picture we're using a transmission electron. This is the animal we're fighting that's invisible to our eyes, but you can see how invasive it is attacking a cell. So it's kind of a machine gun attack. A quick review that we initially thought that it was attacking the lungs, and now we have learned it's really attacking every internal part of the body and attaching to the ACE2 receptor, which unfortunately is what leads to the blood clots and all the problems with strokes and heart attacks. And so it's good news, bad news. We understand the mechanism of action better, and now we're trying drugs that works on this ACE2 receptors to slow the growth of the virus inside the body. And this is other ways we need to identify people at higher risk. And now we're learning more and more about what are some people having more serious consequences than others. And it has not been confirmed from multiple directions now that there is a relationship with your genes and the fact you're at higher risk. We talked a couple of weeks ago for the first time that there may be a relationship with a type of blood. That has not been confirmed by multiple type of reports. I have all the links here, but pretty much the type A blood types have a bigger red cell coverage, and they have a 50% higher chance of having more complication. The type O has half that risk. So the ratio between type A and type O is 2x. So depending what your blood type is, and unfortunately I'm type A, you need to be more risk adverse if you have a higher risk. They also have discovered that on chromosome 3, there is something that is linked bad consequences. And that's home to 6 genes, including the famous gene that interact with this ACE2 that I talked about earlier. So this ACE2 is the attachment that the virus does to get into the cell. So now that we understand more and more who is at risk and what type of drug it is, we may want to be much more proactive in treating these patients who have these gene mutations earlier, as opposed to waiting in day 7 to 9 if they have that inflection point and need to be hospitalized. For some of you gentlemen, there's no relationship with being bald. And I'm not looking at the screen, so don't be angry at me. But there's a study coming out of Brown University using data from Spain, and this was stunning. 79% of the men admitted to the hospital had some form of baldness. Now remember, over 60% of the people hospitalized were men. So you really have that bias there. But and then there was another study published in another journal, so there's another data set showing 71%. So it's very consistent. So what you want to see 2 or 3 studies before you take it too seriously, because people now are publishing without peer review. And so, but now there's clearly some pattern there. It only means that if you have some of this genetic risk, you just need to be more careful and be a bit more risk adverse. And we're learning literally every week more information there. So another data just came out is that as we're reopening up, most people are using these temperature guns to basically check to see your temperature. Well, this is an interesting data set. New York just published an analysis on 5,700 patients, so it's a pretty statistically and significant. And they look at all the people who got hospitalized. So these are the 20% of people who get the virus, who get really sick, that needs to be hospitalized. 70% of those people, they had no temperature when they went into the ER. Now think about this. These are the sickest ones. Looking at temperature is not enough of an indicator to really know if somebody is contagious. I just want to affiliate that. So the fact that a lot of people for restaurants and work are doing that doesn't mean that you are safe with the data we have so far. Now, the other thing that was interesting with confirming this is that 42% of the people who end up in the hospital were obese. There's a very strong link with obesity and diabetes. 57% have hypertension. So again, if you're obese and you have hypertension, that means you have a significantly higher risk. You need to be more careful. There's clearly no link to smoking. If anything, some people even thought it was protective, but majority of them were not smokers. That means that the fact that, there was no lung damage. And so anyway, so you can take a look there. There's a lot of analysis by asthma and all of that. Asthma was not a big leader there. So it's really cardiovascular is the biggest determinant if you have a higher risk of going into the hospital and being admitted. This is a big data there, but it's worth spending a few minutes on it. So Harvard just published this week a longitudinal mapping showing what are the odds of you getting the disease. And it's kind of interesting to look at that. And the odds ratio is 1:1 is the average. Okay? So anything above 1 means you have a higher risk. And if you have a 2 here, which some of them are very close to it, these are very high. That means you have twice the risk. So a few things to look at: Hispanic and African American clearly have a higher chance of getting the disease. So are pregnant women, which is a problem there because, as you know, there's been quite a few delivery, and the fetus does get the virus if the mother unfortunately is pregnant. And clearly, if you look at the most predictive criteria to determine if you have been exposed to the virus, is the loss of smell, is the leading indicator. Fever is maybe half of that, and so is the cough. So clearly, this group of indicator is the driver there. And most people acquire this in their household, not outside. Okay, so muscle pain, nasal congestions. The problem with dry cough, muscle pain, nasal congestion is that if you look at people who are positive and people who didn't have it, it's not really predictive. The only one where you see a big difference between people who didn't have the virus, which is the blue line, and the people who have the virus is the loss of taste and smell. So if you have anything that's suspicious there, don't just rely on these, because this could be the flu, the cold, and other things, but really rely on this. This is the clear-cut predictor. Everything else, it's a mixture. You can see the blue and the red bar are very close to each other there. So when and what to test. Remember, there is different testing depending where you are. So if you look at the time where before you have any symptoms onset, which is the dotted bar here, a lot of people are the most contagious before they have symptoms, 2 to 5 days before. And so that's when, unfortunately, this virus is spreading. There's this big thing with the World Health Organization this week about perisymptomatic and asymptomatic. It pretty makes that most of the transmissions are people happening before they have symptoms. That's kind of the big argument here. That means the PCR, which is the test to look at the viral DNA, is only valid for a couple of weeks after you've been exposed, and then you have to look at the antibody. And as you know, there's different type of antibody. What looks to be a good indicator is the stool. And we talked last week about people looking at the sewer system, and it has a 2-week predictive value of an epidemic in that region there. So hopefully some of our health professionals and politicians there will start doing the analysis of some of the sewage plants there to just see if there's a hotspot coming up into that region. So one of you asked me a week ago to say, what about dogs? And it turns out Belgium, of all things, Belgian Malinois, which is a kind of a German Shepherd type, they've trained them in France, and with 8 dogs, 4 dogs had a perfect score, which is better than we can do right now with the testing. And the other 4 dogs were between 83 to 94%, which is, you know, some of the sensitivity of the antibodies. So not only they were able to detect the people were confirmed positive, but they were able to detect 2 people that were supposed to be negative, and when they retest them, long and behold, they were positive. So the dog nose, as you know, is 100 million times more sensitive than human nose. So maybe we'll get at airports, and then in addition to the dog that sniff for your drugs, you know, in the bags, you know, maybe they can use some of that. No, it's hard to scale, but they were able to train these dogs in a short period of time. So that's kind of interesting. Another thing that's interesting in China is that they were able to predict the hotspot by looking at social media. There was a bit of a second wave that happened part of China there. And so now they're developing this tool, which has a lot of privacy issue, about doing digital surveillance of social media posting to predict the area where a hotspot is coming up. And there's a lot of discussion in the US about doing this. And of course, there's a lot of argument about where is this data going, especially your iPad, like we discussed last time, and your GPS and all your interaction with people. Let's talk about the vaccine. Just a reality check. Historically, if you look at the success of clinical trials for vaccine, you can see on the average, it's around, you know, between 15% to 30% for most of the vaccine. Good news, infectious disease is 35%, but that means that 2/3 of the time they fail. There's different vaccine. I won't go into all the details. We spent quite a bit of time on that last time, but let's look about what's happening there. There's now 161 vaccines, so it's still going up. We were over 100 a couple of weeks ago there. The RNA vaccine, which is a new type of technology, is the #1 moving the fastest there. There's like 21. What's the good news is phase 1, phase 2, phase 3. So phase 1 is when you're just looking at the safety. So several people did that very quickly with 30 to 50 patients. So phase 2 is when you do hundreds of patients and you start to see the first end of efficacy. Phase 3 is when you do tens of thousands of patients and you're looking at safety in larger scales as well as efficacy in larger scales. So you can see there is this long list of this, and they're coming from different directions. So Beijing has several vaccine in trials, like 3 of them here. University of Oxford, you know, which is England, teamed up with AstraZeneca for working with the US and the UK. And Moderna, I'll talk a bit more about that, is US based. So we have a lot of effort worldwide going on. You can see there's a long list of some really big pharma company who are in preclinicals, who are harvesting antibody and trying to basically identify part of the virus that they can attack. So the good news for us is that we have the best and the brightest across the world. This has never been seen before, which is like a world effort in trying to combat the vaccine. And in a period of a couple of weeks, we basically have gone from phase 1, which is a few weeks ago, to phase 2. If you really want to go to your heart content, there's this long list of vaccines. The Milken Institute track every vaccine. And you can see we're starting to move to phase 1, phase 2, which wasn't the case a few weeks ago. Moderna is the one that's the furthest ahead in the US. They just announced yesterday that they got approval by the FDA to start a phase 3 protocol, which will start in July. And they're doing this in parallel to still collecting the data from the phase 2. They're building a manufacturing capacity for 500 million doses. So they're doing parallel tracking as opposed to you do phase 1, then you do phase 2, then you do phase 3, then you build a plant. And they do 2 injections 28 days apart. They have done one first cohort of 300 healthy patients, but they're still following them, so there's no data has been published yet. They're doing a second cohort of people between 18 to 54 and about 55, and they're having a placebo control. That means that some people get nothing, they don't know it, and then some people get the vaccine. So that's the type of controlled trials that you want to make sure it's correct. So that's the good news. It's moving really fast. Now we have to see if it works. This is something interesting that just came out. We talked that using an existing vaccine may be able to boost the immune system for the next 12 to 18 months until a targeted vaccine to COVID, is available to the population there. And there's an interesting data looking at MMR, and that's the measles, mumps, and rubella. And what they have shown is that there may be an explanation about why there is such a big difference in mortality rate at the age of 50. And they look at countries there where they had MMR, and for the population of the last 20 or 30 years, but they didn't have it, let's say, a long time ago. And you can see that there's a big difference there, which they believe may be due to the fact that some of the population had the MMR in their system there, so they have a stronger immune system to respond and therefore more protected. But the elderly population that didn't have the exposure to the MMR, like a lot of us in Europe, we didn't have any of those tests. We just got those diseases when we were younger. So we have to see if it continues there. But there's an article that just came out, which seems to be credible, saying there's fewer deaths for people who are in highly vaccinated populations there. So if that continues to be proven, it could be a quick fix in the short term to basically do a very safe boost of the vaccine and basically boost your immune system there. But we have to see if it confirms itself. So for example, remember Belgium has this high mortality rate where we didn't have an MMR. We just got the disease. I remember when I was a kid, I basically got all of them, and that was the way we went. There's something in that vaccine that you can see in countries like Germany, they had a very high coverage. So they have a significant lower mortality rate. Because we're trying to understand why some people in countries next to each other having such different mortality rates. So that's hopeful, and so you can see that it's something that hopefully people continue to work on. There's some big healthcare leaders pushing this. There's 426 treatment in trials, so that's also going up. If you remember, we really try to go after that ACE2, which is the spike of the virus. That's how it attached. That's the first protection. If you could stop the attachment there, then you don't have the virus going into the cell and duplicating inside the cell and contaminating and all the cells around it. So there's a lot of efforts you can see at different part of the process of how basically the virus goes inside the body to stop it. So basically stopping the attachment there is the most effective way to do it. And then there is a whole bunch of different approaches after it got inside the cell that people are trying to develop there. So, but you can see the direct attached to the SARS is the majority of the therapy. There's also some good news with Eli Lilly, which is one of the biggest pharma company in the world. They have a drug that's using antibody therapy, and they are doing a double-blind phase 1 trial in New York, in Los Angeles, and Atlanta. It could be available by autumn because it's antibody. It's not a vaccine. It's basically boosting your immune system there. And that could be, again, something that in the 18 months we need at minimum to get a vaccine, will help us kind of boost the immune system there. They're collaborating with a biotech company in Canada. And what they did is that they took the antibody of a patient that recovered. They identify it and they multiply it. And that's basically the base of the technology there, which is much more effective than placenta because you can basically build it in really high quantity. And so it's a monoclonal antibody, which means it's IV, intravenous injections. It's unfortunately not cheap. So we have to see, how that works out into our ability there. In the lab, it shows it works, but we have to look at in humans there. They have begun the manufacturing process. Everybody's doing parallel tracking, so everybody's taking huge bets, spending billions of dollars on things that are not proven there. So we'll see where that goes in a year. Long list of antibody trials. They're not the only one there, but they are the one that have the best data and the furthest along. The good news is that you can get on market very quickly as antibodies, because it doesn't have the type of safety issue that some of the vaccines may have in it. Antivirals is another one, which is using some existing drugs that have been approved for antivirals. We first tried the HIV, but they didn't work out. So now we're basically going down the list of all the antivirals to basically see if they could be effective there. And you can see every pharma company is looking on it. Convalescent plasma, if you remember how that works, is that you have a patient that has recovered. They take the blood, they spin the blood, they basically take the plasma, which is that yellow liquid there, and they basically inject it to somebody. What seems to be the case so far is that if you are in that phase where you're mild to medium there before you get hospitalized, it doesn't seem to really help you. If you're very, very sick on the ventilator, it doesn't help you either. Is that period there between 7 to 10 days where you get to the hospitals there, you need assistance there, you're not really very, very sick yet, it seems to be helping boosting the system there. So we have to see, how practical that solution is. Hydroxychloroquine, it's still not working. There was a lot of controversy about this Lancet paper there that was officially retracted, which is unheard of in the medical publication business there. So there's still trials going on, but there's a lot of data, including one that came out from the UK showing on 1,500 patients there that you were 11% more likely to die. So, so far the data is very negative on that drug, so please don't take it. As a result of all this knowledge, what people are doing, which is why you see a low mortality rate than what happens, for example, in New York and Europe, is that we're trying to treat the patient earlier. We don't wait for them to be really, really sick, because we know that when they end up intubated, it's too late, and that's why we had up to 88% mortality rate in New York. So now we start to give antivirals to people as soon as they're high risk and signs that they may go into the cytokine storm. They may even give the convalescent plasma there. And the thing that's a big change is that we discovered that by putting people on this ventilator with high pressure was doing more harm than good. So now there's a data just came out that shows if you use what's called a helmet, so you get oxygen within a helmet on your face, that's the type of technology that has the lowest mortality. The next phase is a face mask. You may have seen this on television. They put a face mask and they push oxygen. And then the high flow nasal cannula, which is a little tube that goes into your nose. These all have better mortality outcome than being intubated. So the irony is that we're building 200,000 ventilators, and I'm not sure what we're going to do with them. So we'll keep an eye on that. And then we start giving anticoagulant because of that big problem there with blood clots. That a lot of people are having a secondary problem with that. So, and now there's a whole bunch of companies starting developing monitoring capability at home, from the big guys like the Apple, all the way to startups, monitoring your oxygen, your heart rate, and your vital signs to give an early indicator, because a lot of people have what's called hypoxia. They feel fine until they crash, and you want to catch them earlier so we can treat them at home, hopefully in a safer environment than to be intubated. So lots of issue about how we're going to do contact tracing as we're reopening the country. There's a long list of surveillance apps. You can see every country is doing their things. There's no coordination. There's a lot of concern about the government having access to this data about everywhere you have been, the GPS location, every person you met is a powerful trove of data. And what we're going to do with that information, including your vital signs. So it's and only 16 of these 50 apps have protection of the data. So 20 of these apps are issued by the government. So you're going to hear a lot about this. European is stepping up with a lot of new regulation for data protection. There's talk in the US, but nothing has been passed yet. So that's going to heat up in the next couple of weeks. This is an interesting survey. they surveyed 511 epidemiologists, and they asked them basic question we're all asking ourselves, which is, when will it be safe, for example, for you to pick up your mail without protection? And they say this summer. When would it be safe to go to a wedding, to hug or shake the hands of somebody? That's a year. To go out with somebody you don't know, to attend your religious service. And you can see these are the experts, and they're pretty, conservative there. They wait a year for basically a high population, high density event. And then as far as 3 to 12 months is to go to small dinner party, which is 10 people, work in a shared office, and then this is, and then, eat at a dining restaurant there. So you can see these are pretty conservative. And most of the countries not doing this, which may be why we see the upswing. Another way to look at this is to say, when could a school, when it would be safe to go back to school? I know some of you were interested in that. And you can see it's a bit of a spread there. I mean, I think the school will open in the fall for sure, but only 40% felt it was very safe. If you look at hugs and handshakes, that may be something that disappears in American culture. It's pretty much going to be up to a year. An airplane, big problem for the airline industry, unsafe in their mind. So another one is, when you stop wearing masks. That was surprising, at least a year. So get yourself some nice mask and maybe get some nice decoration on it. And this is also surprising, visiting the elderly, 39%. And that's the big worry, that you accidentally infect a loved one, when you visit them. And meeting with new people. So much for trade shows and conferences. 1 year. Okay.
And in terms of meeting the elderly, as the U.S. and our local area increases the level of testing, like we actually went and got our test, and then we immediately, after we got the results, we immediately went to go visit my mom, because we figured, okay, we're confirmed negative, and then we left. And we know next time, we don't know what that's going to be, but
Exactly. And then hopefully, and I didn't talk about this week, but there's a lot of new tests using saliva that are coming out and that you can use at home. They've not been approved yet. But as soon as these tests become available, then, you do your test, which hopefully is something you can do, like a pregnancy test at home. You can find out if you've been exposed or not. And then in that case, if you know you're negative, you can do it. But I mean, that just tells you how pessimistic these people are. Let's talk about the economy. You can see retail in-store visit dropped like a rock, but online did fine. That's why Amazon is racking it in, as we call it. They've hired a lot of people. You can see that we reopened very differently in different parts of the country. So Phoenix is clearly having a problem, but then you can see Denver is still managing it very well, and Milwaukee. And so when we say there's an upswing in the country, it's really literally state by state, city by city. Part of that is how well people are, following the distancing and the mask and going out. But, we have people who are very individualistic, like in Florida, you can see they're going straight up. So we're going to have to keep an eye on that. You can see the opening of the economy, and bada boom, it tripled. Same thing here in Tampa, they reopened here, and you can see it close to triple. So these are concerning, and I don't think we're going to shut down the economy again, but I think we have to get people to be aware that they have to be accountable and take distance. San Francisco Bay Area, you can see driving is up, walking is up, transit is still being ignored for, the high density problem there. Unemployment claim, 1.5 million new people filed last week. I think it's estimated to be 25 million people now are receiving unemployment there. You see, historically, it's massive compared to what we call the Great Recession. So we're clearly living history. As far as the economy, there's 44 million people who have filed for claims. That's massive in a short period of time. And job creation, there was a surprise job creation there. And interesting is the leisure and hospitality, but that's probably because they laid off all the hotels and now they're rehiring them. And the government laid off people, so that's interesting. So as you know, if you watch the stock market, we had a bit of an awakening yesterday where the stock market is discovering that maybe this whole COVID thing is there for a while anyway. And we dropped like 6%, which in perspective, that's one of the biggest drop we had for a while. compared to when we had the big drop in March. It's the the fourth largest drop. So the market is volatile. I think there's a lot of confusion where the market is going. You can see the market had recovered quite a bit there, so you probably expect a correction there, but we still haven't fully figured out if the COVID comes back and what that's going to do to the economy.